Well, it gives me great pleasure to introduce my friend Georg Böhmig from Vienna. Georg is a nephrologist and immunologist, especially in clinical immunology, and trained at the University of Vienna in medicine, and also at the Vienna Institute of Immunology, where he's really got detailed capabilities in testing patient material. And I emphasize that because what he's been able to do is put together programs in which you're simultaneously getting all aspects of the patient, the clinical phenotype, the histopathology, the molecular pathology, and then the monitoring of blood cells and monitoring of donor-specific antibody. And very few places, perhaps no place in the world, can put this together. And that's what makes him such a prominent investigator. Arguably, Georg has emerged as the most prominent researcher currently in all of kidney transplantation internationally. He's published more than 240 peer-reviewed articles. And his research is, you could say it's translational, but I see it also as being extremely basic, asking the most fundamental questions about how things actually work in patients. His major interest has been in antibody-mediated rejection, and his first papers in this respect caught my attention in 2002 when he was one of the very first to really show the full extent of antibody-mediated rejection in its acute and chronic phases. So he's going to, everyone knows his New England Journal paper that appeared in May and had created quite a ripple across the kidney transplant world and across all of transplantation. So he's going to talk to us about that today and how he is targeting CD38 and antibody-mediated rejection. I should just note the land acknowledgement in enjoying this special treat when having our friend from Vienna talking. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the languages and cultures of the First Nations, Métis and Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And with that, I'm delighted to say, go ahead, Georg.
So many thanks, Phil, for this kind introduction. So I try now to open my file. I hope you can see it. Yes, can you see it?
Yes.
Yes, perfect.
Yes. So thank you for this introduction, Phil. Of course, I want to point out here that Phil is in my scientific career an important teacher. So I've learned a lot from him. And I guess a majority of our research activities is based on the work of Phil and is also based on the cooperations with the Edmonton group. So this has to be appreciated, of course. And so I would go on with treatment of antibody-mediated rejection using the concept of CD38 targeting, as Phil has already mentioned. And maybe just a few words in advance. I try to switch on. We all know that according to the Banff classification, antibody-mediated rejection categorization is complex. So, but a major lesion we see histologically in AMR is microvascular inflammation. And at this point, I want to mention that Phil was one of the first who described this phenotype as a possible feature of antibody-mediated inflammation or injury. And the major lesions are glomerulitis and peritubular capillaritis, and the sum score is called the so-called NVI score. And now it has turned out that in some instances, this feature of NVI or this score is not associated with detectable donor-specific antibodies in the circulation. And this has led to the new subcategory of NVI, C4d negative and DSA negative. There's a lot of discussion today whether this is really not DSA dependent or whether there are DSA involved, but it's important to study this phenotype also in the context of treatment. And another subcategory is now the probable active AMR category with some sub-threshold MVI. And then if there's an ongoing process of AMR, we can acquire chronic lesions in the microcirculation, and the typical lesion is glomerulopathy and basement membrane multilayering in the peritubular capillaries. And there are two phenotypes according to the BAM scheme, chronic active AMR, and this is the major interest of our study group. And on the other hand, the phenotype of chronic AMR without any significant MVI could be a phenotype of burned out chronic active AMR. And on the other hand, our dichotomous view tells us that there could be the phenotype of TCMR, which is can be regarded as a separate phenotype in the spectrum of rejection phenotypes. So with this, I want to shortly comment on the clinical implications associated with AMR. So AMR is frequent. It's estimated to occur in about 3 to 12% of the kidney transplant recipients. It has an immense clinical impact. In some studies, even a tenfold increase in the risk of graft loss. Maybe this is an overestimation, but other studies have shown an about 2 to 3-fold increased risk of graft failure in the long term. And of course, it's associated with high costs because we try to treat this rejection with sometimes expensive treatment approaches, and it has been estimated according to Medicare and Medicaid data that there's a plus of $35,000 per patient per year over 2 years after the diagnosis of AMR. And finally, we have the problem that we have no treatment. So there's no treatment with a strong evidence behind it. And there is, as I will mention, a standard of care treatment, a so-called standard of care, but this is based on expert opinion, less on trials or evidence-based medicine. So this paper has now very recently been published in the New England Journal by the group of Lupi and co-workers. So this is a multi-center cohort study evaluating the impact or the association of the different BAMF22 phenotypes, no rejection, antibody-mediated rejection, probable AMR, and this MVI, DSA negative and C4D negative phenotype with long-term outcomes. And you can see that the worst outcome is observed in the AMR group. There's also worse outcome in the MVI DSA negative group. So it's a little bit in between no rejection and rejection. And the probable AMR phenotype is associated with some, but not with a significant increase in the rate of transplant loss. So I guess this paper can be discussed, of course, but the overall message is we have phenotypes with an impact on long-term graft survival. And these outcome data are in the context of treatment. So we have apparently no treatment which is able to improve significantly the outcomes in the long term. And then there could be a conventional pathophysiologic view on the process leading to donor-specific antibody-mediated injury in the microcirculation. And the conventional view is that there's a T-cell dependent B-cell activation, differentiation to memory B-cells and plasmablasts, and finally long-lived plasma cells in the bone marrow, which are then producing donor-specific antibodies. And the donor-specific antibodies are usually directed against HLA antigens, and they can cause injury via direct signaling, theoretically. There are some experimental studies on that. they can activate complement. Complement may play some role in the early phase after transplantation, but it's controversially discussed. And finally, it has become clear that there are FC-dependent cellular mechanisms where a main population involved is the natural killer cell population. This has been primarily described by the Edmonton group according to transcriptomic data. And then if you look at the sequence of AMR, the pathophysiologic sequence, there could be different types of treatment interfering with different steps in the sequence, like early co-stimulation blockade, CD20 interference, interleukin-6 targeting, proteasome inhibition. So there are different concepts that have been studied. Removal of antibodies like apheresis, imlifidase, and now an interesting agent, efgartigimod, which decreases substantially the half-life of antibody, complement blockers, and finally, of course, of major interest, given the important causative role of effector cells and K cells targeting CD38, because CD38 is highly expressed on plasma cells on the one hand, so it could lead to plasma cell depletion, and on the other hand, highly expressed on NK cells, so could also interfere with the NK cell triggered process of injury. And then this is what we have now. That's the status quo. And I guess it's well reflected by the 2019 expert consensus of the Transplantation Society Working Group, which it's a little bit complex, this table, but the major recommendation is for early AMR, the use of plasmapheresis together with IVIG. So this is the so-called standard of care based on cohort studies, but there's definitely no well-designed randomized trial to prove that plasmapheresis and IVIG is effective. And you can see that for late AMR or chronic active AMR, the major recommendation is optimization of baseline immunosuppression, whatever that means. So they recommend an increase in tacrolimus target levels above 5 nanogram per milliliter and addition of steroids in case of a regimen without steroids. But one can expect that this change in baseline immunosuppression would not have a major effect on the course of AMR. And then there, on the right column, you can see that there are different treatments demonstrated to be effective in case reports, anecdotal reports like complement interference in the early phase after transplantation. Rituximab is still in this consensus, even though there's no study showing that rituximab is effective in the controlled trials. And even splenectomy. There are some case series suggesting that in the very early phase, in very severe AMR cases, splenectomy could ameliorate the course. But the evidence level, as you can see, so there are evidence levels of 3C up to 2C are very low. And then this is the landscape of the current trials. So you can see that there are several trials that have already been finished, some of them prematurely terminated because of inefficacy of the tested regimen, or because of financial constraints or difficulties with recruitment of patients. That's really a problem in these AMR studies. And some were completed and finished and have revealed negative results. And these are, for example, the recent imlifidase trial, phase 2 trial, the bortezomib trial performed in Vienna, rituximab trials, which were all negative, and the clazakizumab trial, an IL-6 antibody, in a phase 2 study, some effect may be, but in a large phase 3 trial, now the Imagine trial, it produced a negative result in the context of evaluation of eGFR slope. So this study was terminated. And at the end, we have the situation that we have no treatment proven to be effective in a phase 3 trial, for example. And now I would like to focus on felzartamab. Felzartamab has now been tested in a phase 2 trial. What is felzartamab? It's an antibody, a human, fully human antibody IgG isotype directed against CD38. And as I mentioned, it could bind to plasma cells and NK cells because CD38 is expressed on these cells at very high levels. CD38 itself is an extremely interesting molecule. It's an ectoenzymatic glycoprotein, has many functions, including functions in cell migration, metabolism, and so on. And it could be that targeting CD38 has some other effects, which are apart from depleting simply NK cells or plasma cells. And these are some details on felzartamab on the right. The primary mode of action with the use of CD38 antibodies might be important. There are some specificities for felzartamab, so it is not able to activate complement to lyse cells. This mechanism on cells is just lysis of target cells via antibody-dependent cellular cytotoxicity, ADCC, or phagocytosis. And this is important when considering the effects of felzartamab in the felzartamab trial, which has now been published. Here is a complex slide, just highlighting the different modes of action of CD38 antibodies, which might differ between the different proponents. So there are in general, there are 3 different CD38 antibodies in use. That's daratumumab for myeloma treatment, as well as isatuximab, and now felzartamab. And there are some other antibodies, but just in the experimental phase. And you can see that the different modes of actions are not the same with the different antibodies. So this could be, for example, inhibition of the CD38 ectoenzymatic function, which is a domain of isatuximab. Complement activation, in contrast, is a domain of daratumumab. And you can see that felzartamab has no effect on the ectoenzymatic function or on complement. There could be direct signaling to induce apoptosis by isatuximab. And felzartamab seems to trigger mainly ADCC. And ADCC is mediated by NK cells. So it's a little bit funny if you consider what this mode of action is. So NK cells are killed, and at the same time they are killed by NK cells. So it could be that the action of felzartamab is fratricide, that NK cells kill themselves, so that at the end the capacity of the organism to trigger ADCC is limited, and this could also limit the effect on other cells. But I guess this is only theory and should be proven in, for example, in vitro experiments. Now this trial was a phase 2 trial, which was performed in Berlin and in Vienna. It's an exploratory trial without a sample size calculation based on a primary endpoint. So it was rather to understand what is the safety and efficacy of this treatment, to learn and to inform a larger trial. And included were DSA positive patients with active or chronic active AMR, more than 180 days post-transplantation. So these were relatively stable patients because we used placebo as a comparator, which is difficult in an early, severe, clinically overt case of AMR. 22 patients were included, randomized to receive felzartamab for 6 months versus placebo, and then there was a biopsy performed, and the study was opened to an observational period, and after another half year at week 52, a second follow-up biopsy was performed. And a major feature of the study was that we have tried to collect as many information as possible. So this is on the one hand the biopsy-based workup, including of course transcriptomics analysis, and this was a wonderful cooperation with the Edmonton group. and also to understand what is the impact on DSA characteristics, what is the impact on peripheral blood cells, NK cells, are they depleted or not, and what is happening with injury biomarker, donor-derived cell-free DNA, because we think that this is an important marker, as has been shown by the Trifecta study and other studies, associating cell-free DNA with the activity of antibody-mediated rejection, and some clinical parameters. The primary endpoint, if we want to call it primary endpoint, was safety. And we were happy to see that this treatment was safe. At the end, there was some increase in the total number of adverse events, but most of these events were both in the placebo and the treatment group mild to maximum of moderate. And among treatment-related adverse events, so the overall rate was higher, significantly higher in the felzartamab group. The major adverse event was infusion-related reactions, and this is very well known for CD38 antibodies, that they can trigger headache, fever, arthralgias, and stuffy nose, and some first dose effects, which are usually easily to manage. So there were 8 such reactions. They were limited to the first dose. They were easily treated by symptomatic treatment, so not really a concern. And the serious adverse events were numerically not different. There were 7 in the placebo group and only 2 in the felzartamab group. So initially, when designing the trial, we feared that there could be a risk of infection, severe infection, but this did not occur. And on the opposite, for example, COVID was a problem in the study because it was performed partly during the COVID time. The clinical presentation of COVID was much less severe in the felzartamab group as compared to the placebo group, which is interesting. This could be by chance, but maybe there's an effect behind this observation. Now, the major result was that we could reduce the activity of AMR measured by histologically using the MVI score. So at the end of the 11 felzartamab treated patients, 9 became antibody-mediated rejection negative, I would say, according to the MVI presentation in the biopsy. But you can also see on the right panel that there is some recurrence of disease. After stopping treatment and after a 6-month observation period, there were 3 patients who turned AMR negative, showing again MVI and again being classified as active or chronic active AMR. At the end, the result was really impressive because it was a 9 of 11 patients versus 2 of 10 patients in the placebo group. 1 patient in the placebo group lost his allograft before the first follow-up biopsy, and the difference was immense, so it was a 61% difference, but a recurrence of disease. We believe that the molecular platform is even more accurate than the histologic analysis. And this was an extremely important result, that the molecular AMR classifier retrieved from the MNDX platform, from the transcriptomics analysis, was markedly decreased by felzartamab, as you can see, with the red box plots. And then you can see molecularly that there's a full recurrence of disease. So this is even more than we have seen with histology. And I guess this is a concern which has to be considered regarding the duration of treatment. There were no molecular features of TCMR, so this was a little bit a fear of us because CD38 is also expressed on regulatory B cells and T cells, and there could be some depletion of regulatory cells and some trigger for other types of rejection, but it didn't occur in our study. And also a very important result, that we could completely downregulate or reduce the cell-free DNA levels, either the fractions or the absolute levels, and there's a slow recurrence of cell-free DNA over time, not to baseline levels, but what you can see is that apparently treatment blocks injury relatively fastly. Peripheral NK cell count showed that there's a depletion of particularly the CD16 Fc gamma receptor 3A positive NK cell populations and some recurrence. Molecularly, NK cells are kicked out within the transplant, so the NK cell associated transcripts are markedly reduced and then again show recurrence. And this was really surprising. There's no effect on donor-specific antibodies. So was no difference between the placebo group and the treatment group regarding the levels of anti-HLA donor-specific antibodies. Our interpretation now is that it could be that NK cells are killed by felzartamab, and then they are lost for ADCC to kill plasma cells. But maybe it's too simple, maybe there are other explanations, we will see. Regarding the cell-free DNA levels, we have now some more granular data, and this here is a figure showing how fast cell-free DNA is reduced. So this is a logarithmic scale. The effect is really tremendous and very fast. So within a couple of weeks, we get it down to 0 in some patients. That's interesting. We do not believe that the effect on injury can be due to some change in the donor-specific antibody pattern. Some may be, but be careful interpreting this data, some effect on eGFR slope. The slope was, as in many other studies in the placebo group, around 4 to 5, minus 4 to 5, and the slope was nearly 0 in the felzartamab group, but there's a lot of heterogeneity and it's difficult to interpret this data. And the same is true for proteinuria, but I guess you can see that there was no immediate or later effect on the levels of proteinuria apparently, which we did not expect because I do not think that transplant glomerulopathy will resolve within a couple of months. Yeah, iBox, we can discuss iBox. It's based on clinical biopsy parameters, and biopsy parameters include, for example, G, PTC, I and T score and CG score. And not unexpected, felzartamab modulated also the iBox score and led to the prediction of a better graft survival. But interestingly, if you look at the right panel, this effect was lost after another 6 months observational period. But I would not overinterpret this data, but it was interesting to see what the impact on iBox could be. iBox is not yet validated for late AMR clinical studies as an endpoint. And now this is fascinating stuff. Phil knows a lot more about it because this study was performed with together with the Edmonton group, a detailed analysis of the biopsies using the transcriptomics approach. Just maybe shortly show you some of the data. There was a modulation of transcripts which are typically associated with AMR by felzartamab, so this was expected. There was no increase of dedicated transcripts which would explain anything, I guess, in the plot in the middle and in the left. And the genes were changed, and then these changes showed resolution after 52 weeks. So there's reversal of the effects. And the major genes affected are interferon gamma inducible AMR activity genes and NK cell genes. Yeah, this study, I have only one slide, so I hope Phil, uh, maybe Phil can tell us a bit more. But what you can also see is that there's some impact on injury pathways, uh, which could also reflect the effect on cell-free DNA. Yeah, now what is our next step? So we have now went on to a phase 2 trial extension, which is ongoing, and we have already some data there. So the idea was that all the patients who have been in this first phase 2 trial and who have shown activity in the follow-up biopsy or in an indication biopsy later on have the opportunity to get felzartamab once again for 6 months. And then the study, this is an open study, of course, and then we stop felzartamab and introduce monthly donor-derived cell-free DNA measurements to guide treatment. As soon as the levels increase, we apply the next dosage of felzartamab. And so this is defined according to thresholds. And we have now included 9 patients, and I can show you some details in the next slide. Maybe just to mention, a phase 3 trial has already been initiated in the US, and Europe will follow. And just to prove that felzartamab is effective in a larger sample. Now to the trial extension data. You can see we have included 9 patients. There were patients who had been on felzartamab, randomized, and then a follow-up, 5 patients, and or randomized to placebo. And all 9 had active rejection at week 52. And then they all received felzartamab, and then again after 6 months they were stopped. And these are the data of the first follow-up biopsy after reinitiation of felzartamab or new initiation of felzartamab, and you can see exactly the same results. We get this extensive reduction in the molecular AMR score, and this is independent whether the patients had already received felzartamab, so there's no resistance due to prior treatment. And it's independent of whether they have received placebo. So they had already a long time of active AMR. And it's still possible to completely reduce the AMR score. And the same is true for the cell-free DNA, which is markedly reduced. So it is apparently reproducible, and which of course makes us all very happy. The MVI effect is also seen, maybe not to this extent, but I guess the message is clear. We can reproduce the felzartamab data published in the New England paper. Very interesting are the cell-free DNA data. So I've picked out 2 examples, but all the patients look the same. The first one has been in the placebo group, and you can see that there's no change in the levels of cell-free DNA. As soon as this patient received felzartamab, there's a marked drop in cell-free DNA, and then you can see after stopping felzartamab some increase, and this led to the application of a next dose of felzartamab. So this is the strategy. If you look at on the right side, this patient was in the felzartamab arm, and you can see felzartamab in the first part of the study reduced the cell-free DNA levels, then they reappeared, felzartamab is reestablished, and again the levels are reduced. Then there's some increase, and we applied felzartamab again. So this is the idea that we use cell-free DNA as for guiding treatment in the long term. We will learn whether the patients need treatment forever or whether it's only 1 or 2 years. Similar maybe to the treatment of vasculitis. At some point, the disease will burn out, but for AMR, we do not know. Now, the concept of CD38 is of course interesting now in the community, and there are many case reports on daratumumab, and I will not get into detail. The message is in all these case reports, it was effective either in early AMR, severe refractory AMR, in chronic active AMR. So the concept seems to be effective. And this is, for example, a case from Leipzig in Germany. And you see this shaded area, that cell-free DNA. The patient has received a lot of treatments. It's complex, this slide, but was a severe rejection phenotype. And as soon as they started daratumumab, there was a fast drop in cell-free DNA levels and improvement of kidney function and resolution of rejection. Andrei Wiklitsky from Prague has an interesting case, which is very well characterized, including the molecular microscope, of course, histology, cell-free DNA. And just to sum it up, it's exactly the same we have seen in the felzartamab study. You can completely knock out the rejection process, the molecular phenotypes turns back to a normal phenotype nearly, and cell-free DNA normalizes. This is, in my opinion, the most interesting case. It's from Berlin, and they had a 35-year-old female patient with lupus and antiphospholipid syndrome running out of vessels. And the only chance to survive was a transplant, but the patient had 100% PRA, no chance to get a transplant via the transplant list. And there was a living donor, the mother of the patient, who was haploidentical, and there was a positive cytotoxic cross-match, a lot of donor-specific antibodies, and blood group incompatibility. I guess a normal person would never transplant such a patient under these conditions, but this was a young lady and no other chance, so they did it. And the concept was to pre-treat shortly with daratumumab, just to knock out the effector phase, the NK cell effector phase, then deplete the antibodies by imlifidase, add ATG, and then afterwards they even added rituximab, even though the evidence is low, and then afterwards continuation with daratumumab. And the course is really impressing, so they have published this case now. There was normalization of graft function, and there was no rejection in follow-up biopsies. And they used cell-free DNA a couple of months ago. There was some increase in cell-free DNA, so they applied the next dose of daratumumab, and cell-free DNA went back again. So it seems that even though there are many compounds of treatment in this case, the daratumumab maybe allows for transplantation in the context of HLA antibodies and might prevent rejection. Finally, DSA negative MVI is a sub-entity according to the Banff classification, can be theoretically mediated by NK cells independent of donor-specific antibodies, for example, triggered by activating receptors like NKG2C or via HLA-DP mismatches or via missing cells. So that's theoretically possible. But the central player might be NK cells. And this makes it interesting for treatment with CD38. We have in Vienna 3 cases of HLA DSA negative MVI. The first one is maybe really a characteristic case within the C4D DSA negative MVI category, because we really tried everything to characterize an antibody, didn't find anything. It was a severe graft dysfunction early after transplantation, an extensive G plus PTC score, C4D was negative, the V score was 2, and unfortunately we had no MMDX. So now we have it in our routine, but at this time we did not yet have it. And this patient was shortly treated with immunoadsorption without any effect, and then we applied daratumumab, and there was an immediate response. The second case was C4D positive, but in the other components very similar to the first, and also immediately responded to daratumumab. Also no MMDX in the index biopsy, only in the follow-up biopsies. And the third case I would like to mention is maybe the most impressive. This was a young lady receiving an ABO incompatible transplant across a very low gel card titer. but we have learned from Laurie West that gel cards is not everything. It could be behind that a spectrum of dangerous antibodies. And this patient was transplanted without HLA antibodies, and then within a couple of days developed a really extremely severe AMR phenotype associated with high-grade MVI and thrombotic microangiopathy, dialysis-dependent graft dysfunction. And this patient, there we have molecular microscope phenotyping, presented as a mixed phenotype of rejection. And we, as soon as we started with daratumumab, there was a fast resolution of rejection, also molecularly, and the patient is now completely stable. So this means that maybe CD38 treatment could also be applicable for some other types of rejection. In the last case, even T-cell mediated rejection, for example, because this was a mixed case, TCMR involved, and in the follow-up biopsies, we didn't see any TCMR anymore. Yeah, so just to sum it up, AMR is associated with adverse graft survival, and the NK cells are maybe the critical players in this process. There are many negative studies. Unfortunately, now also the Imagine trial evaluating clazakizumab, this anti-IL-6 antibody. We need well-designed trials. It's really difficult to conduct the phase 3 trial, as we have learned from the Imagine trial. Recruitment there was more than 5 years. And we need surrogate endpoints. And I guess targeting CD38 could be a promising concept. Based on the phase 2 data, we will learn a lot, I guess, during the extension trial and the phase 3 trial. And at this point, I want to thank all the collaborators, particularly also the Edmonton group, of course, where we have this wonderful cooperation. So thank you very much for your attention.
Well, thank you very much, Georg. This is one of the most exciting presentations we've seen in a long time, and it's a development that's been long awaited. That, you know, in the beginning of the 2000s, we had lots of clinical trial activity in transplantation, and then it disappeared for 2 decades, and we've had a lot of anecdotes, uncontrolled trials. But your trial in the New England Journal has set the stage for a new era, and I think I'd like to see if you first of all, have you seen applications of this in the heart transplants in Vienna? And secondly, do you think we're moving into a phase where we're thinking not so much of cure, but of suppression of activity, which is the way rheumatoid arthritis, ulcerative colitis, Crohn's disease, and many other diseases are managed with monoclonals, thinking of suppressing activity and following up and treating again as activity recurs. So do we have to change our thinking? First of all, hearts. Secondly, do you see yourself managing chronic disease in the outpatient clinic now and from this point on?
Yeah, regarding hearts, so my colleague Andreas Zuckermann has some experience in using the CD38 antibody daratumumab, and there were indeed some impressive cases. He's now trying to summarize it for publication. I guess it's 6 or 7 cases, and there were really some responders, very dramatic cases, and it seems to be effective. Of course, I guess it's the situation we have with many treatments in heart, that we have only experiences from anecdotal cases and case series, so we have to be careful interpreting that. And I guess the heart will be informed by the kidney, because as soon as we have a positive phase 3 trial, I would expect that the treatments can be also more broadly used in the other organs. But it seems to be effective there. And the other point, yeah, that's, I guess, of course, our thinking was always we should just block the process of antibody production, maybe in the long term, using different agents. And there are now new agents which go in this direction, like bispecific antibodies or CAR T cells. And the felzartamab concept or CD38 concept is maybe rather this just interfering with the effector cell phase of AMR without much effect on antibody or B cell immunity. And this could be advantageous because what we have seen is that there are not really big safety signals, only these infusion reactions, no increase in infections. We have now even used daratumumab for patients who had active polyoma. So there's one case in Vienna, one in Basel, and at the same time AMR seems to be effective there without exacerbating the polyoma problematics. So it does not increase the PCR levels. So it makes it relatively safe apparently. But this means, and I guess we have learned it from the felzartamab trial, that we need maybe long-term treatment. We have to continuously dampen down the effector phase, and it seems to be very selective. It's just the CD16 positive NK cells. The other NK cells apparently do not disappear. So it's so selective, and it was by chance, I would say. So maybe it's a long-term treatment, like in rheumatoid arthritis or in other diseases.
Yeah, so just to add a word of warning, the results are so impressive right now that it could interfere with the recruitment to the phase 3 trials, in which case we would end up in the land of anecdote, where we've been languishing for the last 20 years. It's very important to get the phase 3 trials rapidly recruited so we can move out of anecdote, and to include in the phase 3 trials the C4 negative case, the antibody, the DSA negative cases, and move on to heart transplants, and do this quickly before the world changes so much that you can't do the controlled trials.
That's exactly what it's my opinion also. So now, fortunately, the company, so that's Biogen now, it's a big company, and they have, I guess, the budget in hands to perform several trials. And their interest apparently is now also the DSA negative phenotype, so to extend to DSA negative MVI or treating MVI in more general. And the other step would be indeed to go into the heart. So that's what they are planning, or at least speaking about.
Laurie?
Yeah, this is so exciting, Georg. Thank you so much for spending some time with us to go through this today. I think it's very exciting for potential use in heart. I agree totally with both you and Phil, and I know Andreas is excited maybe about that group in the Vienna cohort as well. The patient that you described with the anti-B titer of the ABO incompatible one with a titer of 1 in 8, is that the patient you sent to us to look at?
Yes, it is. So I guess this will be exciting because Laurie will evaluate her array assay just to see whether the maybe more kidney-specific blood group antibodies are.
Yeah, it's the
affected.
Luminex. It's the Luminex that I think that we're. Yeah, and we'll be excited to share that with you. And the case that had the earlier case you mentioned that had everything under the sun, the daratumumab, the rituximab, the horse equine, the equine ATG, that patient it might be available for study as well?
Yes, I guess. In according to this patient, the Berlin group has started a kind of off-label program. They call it the Berlin program for the ultra highly sensitized patients. So the concept is in the ultra sensitized, you use imlifidase, but we know that imlifidase will lead to a rapid recurrence of antibody levels, and do it under the umbrella of CD38 targeting. And they have now already 3 cases, and they all appear to be stable now. And in my opinion, this is also, I would say, maybe should be a target of our research in the future, just to combine imlifidase or other desensitization strategies with CD38 antibodies. Maybe this is a way to go on.
Very interesting, Georg. I agree with Phil, very exciting.
Thank you.
Yeah, so what's your anticipation about how, are you seeing people lining up to be in the phase 3 trials? There are 2 phase 3 trials ongoing. I thought there was going to be a third with DARA, but there's no sign of that so far, right?
There's I have seen that there's an uncontrolled study in China. It's, to my knowledge, 10-patient study where daratumumab will be evaluated. No information on the status of the study. It's not on the clinicaltrials.gov website. The second study you mentioned, I guess, is another CD38 antibody, and to my knowledge, there's no further research in it. It will not be continued or not be initiated. So there's only one at this point, and that's the Biogen felzartamab study.
I thought there was some activity in clinical trials, in the clinical trials registration, suggesting
Yes.
that there would be additional trials. I think you pointed that out at one point, but there's been no further activity in that respect. We'd really like to see the rest of the other monoclonals being tested before they go into off-label use.
There's this one monoclonal, to my knowledge, the company did not get approval for this trial.
Okay.
But that's just in the newspapers. I've read some sentences about it. So what I think, it's only felzartamab at present. Yeah.
And efgartigimod.
And efgartigimod, of course. Yeah.
So we'll see how that goes. Any other questions for Georg? I'm not seeing any other activity. So, Georg, the CD16 positive NK cell, this is a complex creature. Now, one of the possibilities, molecularly, these diseases are identical, and we can't really see any difference. So that would suggest that really they're fundamentally linked probably through the CD16, which means there is an undetected antibody. And then you start to think about DSA in a different way. And I know this may not be popular with the HLA antibody people, but the DSA that you measure is what has not been absorbed by the kidney or the heart. And the heart or kidney are probably very effective immunoabsorbents. So if it hasn't been measured, it may not be a very good antibody in terms of activating effector mechanisms. So I wonder whether we're really in the phase where we're simply missing the absorbed antibodies. Maybe I'll just leave that thought with you, Anne.
I was already going to raise my hand before you said that, so don't. I wasn't just responding to what you said. But hi, thank you. That was a fantastic presentation. Really enjoyed it. And yeah, as Lori said, these are great opportunities to study the impact of ABO antibodies for, in the setting of all these treatments as well. Yeah, I think I was actually going to comment on what you just said, Phil, as well. Just thinking about, evidence of what we see as a phenotype or genotype, or however type you want to describe it, of antibody-mediated rejection in the absence of HLA antibodies. And we know that there's, the advent of single antigen beads has absolutely revolutionized what we can do in the HLA lab, and it's exciting to see that have happened, but recognizing that nothing is perfect and that there is no perfect lab test. And thinking about not just the testing and performance and limitation of the antibody test itself, but the interpretation of the test, using that thresholds that are lines in the sand versus looking for patterns that you can sometimes see at a 200 MFI, but they're there, and I think as we continue to evolve in the HLA lab side of things, being more using best practices in antibody analysis, where we, are looking at that as a whole picture is really important. Because, and I know your HLA team is excellent. I'm sure they're doing that already, but just in general for studies, I think that's something to think about as we look at these HLA antibody negative, antibody looking phenotypes and cases, that we make sure that there wasn't a signature that was just well below a threshold, but you see this clear stacking and changing of antibodies. And I think that's important place for HLA labs to collaborate with this work too. But yes, excellent presentation. It's really exciting. Thank you so much.
Thank you very much. I guess your comments are so important. For example, in our patient, we of course went back to the HLA lab and they looked at all the possible sub-threshold reactivities, but there was really nothing. So this patient had no antibodies at all. But there's one paper, I really like this paper by Brian Nankivel, who reanalyzed a set of patients with DSA negative, C4d negative AMR very in detail, and he found indeed many samples with subthreshold antibody, shared epitopes, specificities against HLA-DP, for example, which were not characterized before. And finally, very interesting C4d staining phenotypes, which are not standard outside the peritubular capillaries, like in the glomerular capillaries or in the vessels. And he meant, okay, the percentage of the true C4d DSA negative samples is very low if you go this way. But yeah.
Yeah, I think it's such a great point, and I'm glad you pointed out that paper, because I do think, and I know the ASHI HLA community is really making a push to, for best practices in not just testing, but antibody analysis, because also historically we didn't do things like EDTA treat our sera to look for very, very high. I don't like the word prozone because I don't think it's like prozone per se, but complement interference and other things. And now as there's still labs who don't implement that step in their testing, and so I think from an HLA side of things, we need to be pushing our own community to be using best practices in testing, analysis, and reporting so that these phenotypes can be really properly teased out. And that paper you referenced is a great example of that, I think. So, but I know your HLA team is on fire, so I know they're doing a good job. But I think just in general, and I don't want to speak negatively about my own community, but I think we need to really promote doing those things and looking at patterns and looking at, and again, using things like EDTA treatment or other ways of mitigating complement interference in these excellent assays that we use, but there is no perfect lab test. I haven't met one yet. So, I think understanding those limitations is really important.
Just to add, and then trifecta studies, we've been able to take the measurements at 1 lambda, and then Lewis has gone on and looked at the conventional MFI cutoff, then MFI cutoff of 300 and 100. You increased the number of DSA positives, but you didn't increase the association with antibody-mediated rejection because you increased both positives and negatives. So the balanced accuracy of DSA did not improve, and the relationship to cell-free DNA didn't improve. What did improve was if you just said, if you've got MVI and you just assume DSA is positive, you pick up 60% more ABMR cases histologically, so that the lesions are there, the lesions are the same, and making new rules because it's DSA negative is interfering with the diagnosis of the cases. So just calling every case DSA positive actually let the pathologists diagnose ABMR in many more cases than currently, but lowering the threshold per se didn't make any difference.
Yeah, no, I think it has to be done in the context of epitope reactivity. And I know Lewis does that. So, I think it's really important to not just randomly dilute, like say, I'm going to make this my threshold, but it's really critical that we look at the patterns as well as, in the context of decreasing the threshold. It requires that expertise of, understanding patterns of reactivity that many people can do, but it's not universally done. And I think that's, again, where we need to, as a community, an HLA community, really make sure we're doing the right thing to support these studies, as I know Lewis does. But it's not necessarily true of all studies. So I think it's an important consideration.
Sure. I think another consideration is also the fluctuation of DSA levels. And we have seen in the felzartamab trial, for example, there were 3 patients with very low levels, but clear donor-specific antibody positivity. And at the time of initiation of the trial, they were negative. So they were definitely negative. So there's fluctuation. I guess this goes into the direction of what Phil said, that it could be adsorption to the graft. And on the other hand, the New England paper by Lupi includes patients who had preformed donor-specific antibodies in the MVI DSA negative group, and I'm not sure about that. Maybe these patients have a history of DSA positivity, and there could be adsorption at the end. So I guess we should also look at the remote antibody results in such patients.
Yeah, and third party as well is important because it tells you relative to the other ones what might be happening.
I think Sean wants to bring us back to our senses and close the meeting.
No. There is just letting you know there was a comment and a question in the chat as well. I don't know, Dr. Abdallah, if you want to ask your question directly or not. It's related to desensitization in high MFI patients. Oh, did they jump off already? I think people probably had to get back to clinics.
Maybe I could read the comment. I'm seeing it. Sorry, I'm not seeing it. Sean, could you read it?
What is it about CD38 in desensitization in recipients with high MFI? I think, for example, 10,000 and up, and the infection risk.
Yeah, regarding desensitization, I would not use this term for CD38 targeting because actually there's only a very moderate or slight effect on the levels of HLA antibodies, also in the phase before transplantation. So I would not use such agents, and this has been shown in trials for desensitization. This would also mean that you treat a dialysis patient with something which is not really effective in reducing antibodies. So, and this could also lead to some infection risk or whatever. So I guess the idea is desensitization by other procedures like immunoadsorption or imlifidase, and then adding daratumumab in the peritransplant phase to interfere with the NK cell effector phase. So this is the concept. I know that some other people have other ideas there and use these antibodies also for desensitization, but I would not do that.
So I think our thinking is going to change, and maybe we'll have to close at this point because everyone has to get to their clinics. But the thinking now is that the target of control of activity is probably the NK cell rather than DSA, which makes us start to think about different laboratory support for the clinicians who have to make these decisions. But that's where you're going to lead us. So Georg, I would only say continue your leadership. You've been exemplary in showing us how these things should be done and moving toward trials. We absolutely need that kind of activity. So thank you very much for sharing your work with us today. We look forward to seeing you at the next generation of meetings.
Many thanks. It was a pleasure.